Addiction is, it refers to a behavioral syndrome, and that's important to understand, where the procurement and use of a drug seem to dominate the individual's motivation, where normal constraints on the individual's behavior seem largely ineffective. Basically, it doesn't, I mean, you probably have heard of people who have gone into rehab or, you know, some kind of detox program, and as soon as they got out, they went across the street and got something, you know. So the amount, so the normal constraints, things that we would think normal people would go, I'm sure that probably did the trick, and they're not doing that again. You know, for some people, those behaviors are not gonna. I'm not saying they can't be cured, but I'm just saying, just realize that's usually, when we're talking about drug addiction, we're talking about a behavioral syndrome. Drug abuse simply means that the substance is used in a manner that does not conform to social norms. So the motivation to use substance may or may not be particularly strong compared with other motivators. So, you know, a person may use, you know, we know people use recreationally, you know, people, you know, use in different occasions once in a while. But for substance abuse, it means that it's a use in a manner that does not conform to social norms. So, you know, you're abusing when, you know, you drink and then you drive. You know, I mean, and then you know that you're not supposed to be doing that. That's, you know, driving drunk is not all right. And so, so then it would be that, and if you're doing that repeatedly, there's a good chance that you are suffering from some kind of abuse. Or you drink and then you know, get into fights and things like that. Substance dependence, in contrast to the two terms described above, refers to a state where the individual is dependent upon the drug for normal physiological functioning. So that's really important. And when you, I don't know if you remembered from the little HBO video, the gentleman was saying that, you know, he doesn't feel normal when he's not using. And that's so another indicator. So even if you didn't have your MRI, you didn't have, you know, you weren't in a hospital where you could send someone down the hall to have an MRI, just in an interview, you can talk to someone and get some information. Yes, sir.
I find conflict with drug dependence, the definition of that, because I know I've given people dependence diagnoses before and had doctors sign off on them, but those people, when they stopped using, they were going through withdrawals. So I mean, that's my only, like, I'm having trouble, you know what I'm saying, understanding that aspect.
That's a good point. When you look at the DSM on diagnosing drug dependence, and this is just a little brief blurb on drug dependence, but when you look at the DSM, there should be 3 or more of those criteria. Doesn't necessarily mean that they have to experience withdrawal.
Right. Okay.
That's a good point.
Another question.
Yeah. Oh, sorry. Yes.
But isn't the same, like, if you're withdrawing from alcohol, and like you went out the night before and you're experiencing a hangover, I mean, that's an experiencing withdrawal.
Yeah. Yeah.
So no matter how minor it
Because
may
it's
be,
metabolizing. Yeah.
Withdrawal, so.
Yeah. Usually people are talking about getting really, you know, the shakes, tremors, things like that. But I think that's a good point, because I think so many people do have hangovers and like, that's a hangover, you know, and it's like, it's not okay. How often does that happen to you? And when you think about it too, you know, again, going back to the neurological thing, I mean, you have to have done some significant change to your brain, because your brain controls your whole body. So for you to have these kind of physiological responses as a result of some use, and including Coca-Cola or caffeine or whatever, you know, so I'm not, you know, I mean, we're talking about, you know, addiction and abuse and things like that. But I just want to make clear that, you know, to some degree, we're all doing things to change our brain. You know, we're doing things to change our brain. We're doing things to change the way we feel, because, you know, we were up late, you know, studying for an exam. So we're going to, you know, drink a bunch of coffee or Starbucks or whatever. Is his living situation or his relationships, would that be pertinent? Would that be pertinent information to gather in order to understand the level of care that he would need? Okay, can anybody just tell me, one person just tell me why would one of those exist?
Because if he's living with his wife, it kind of sounds like his wife is opposed to the drinking, so she might want to, you know, if he is going to be doing some sort of an outpatient treatment, that, you know, if you can get his wife involved, you can kind of trust that she would maybe provide a positive environment at home for him to be in.
Excellent.
But you also kind of have to wonder how close are his brothers and his cousin to his house. You know, do they live right next door? Do they live, you know, right down the block or whatever? Because it seems like they kind of encourage the drinking. So you got to wonder, you know, who is he going to be around more, and where does he spend the majority of his time?
Okay. And I'm just going to go through this, just again, in the interest of time, I was going to ask, does anybody think that his financial resources might be pertinent?
He's the primary breadwinner.
He's the primary breadwinner?
Then absolutely. And I mean, if he was to be placed in a residential program or a day treatment program, which is what most IOPs are for men, it would definitely impact his ability to collect an income, where he'd have to change his flexibility at, you know, at work. And that's not a very easy thing to do for anybody. That's why a lot of adults are opposed to IOP.
That's what I was going to say, and that gets back to that conversation that we had, that if he needed IOP, he's going to try and talk you out of it.
Absolutely.
And I'm like,
He wants to go to work and then go to IOP for 3 hours, 2 hours, and you know what I mean, afterwards.
Yeah.
Nobody, you know.
yeah. What about past mental health history? Could that in any way be pertinent to?
I mean, if you had like chronic depression, that's the way he maybe self-medicated with it, and you figure that out after like a long discussion, coming down to like the root of his depression was something, but the way he coped with that problem was with his alcoholism, it would be a major issue.
Also, if he's tried to commit suicide, because alcohol is a depressant. Huh?
I mean, the family history too, like his genealogy or whatever, what's going on with that. If there's, you know, chronic illness, you know, history of alcoholism or mental health issues or a combination of the two. My dad was diagnosed with bipolar at only 55. So I mean, he never knew his whole life. He drank to cope with these feelings that he had, but he never was involved with health care. So he just, you know, it went on and on. He had all these problems, and he would drink to cope with losing a job and not being able to get along with somebody. And that's another thing. When's the last time you were at a doctor or stuff like that you need to find out?
You had your hand
He
up.
could, I mean, with 3 DUIs, at least once in those DUIs, he was probably already assessed for substance abuse. Probably not the first DUI, but definitely the second one, he probably got assessed for, you know, substance abuse at the very least.
What about a medical diagnosis, or if he's on any kind of medications? Would that have any relevance to?
Combination could have something to do with why it's disordered. So
Why what?
You're not why it's disordered, like
Mm.
intense medication and alcohol combination.
We got some pharmacologists in here. But yeah, that could have an impact, as well as other disorders such as diabetes can change moods and things that aren't being treated, aren't being addressed. Were you gonna say something?
No, I was gonna say, like, as far as like me getting off, like just like the off the train of thought, when when you're doing it, it's important not to have like a robotic feel, because the most important aspect of this is your assessment is like the foundation of everything for this person's treatment. Like how he interacts. Like his interaction with that first guy was what he's conveying to me was that he didn't enjoy it. You know, he didn't feel like he was connected to that. He, you know, felt like it was bothersome and burdensome or whatever. Anytime I've ever done an assessment, I've always paid a lot of attention trying to establish a really good rapport with the person. You know, going slow enough so that they can get out what they need to say, because a lot of times that's part of the problem is that you know, no one's listening. You no one's listening to them ramble and rant, whatever they want to do. And sometimes you get a lot of valuable information when you just let people go.
That's true. It's true.
So it's hard to establish that, that flow sometimes. Hit all the points,
Right.
because you're just really engaging in conversation that has a goal.
Yeah.
You don't do
And-
that with your friends.
And again, my point in the exercise was to help you all think about why do we ask some of these questions in creating a multi-axial diagnosis, because all of these things can be relevant to us understanding not only is it substance abuse, is it substance dependence, but what kind of care would this person need considering their social supports or lack thereof, their financial resources, their medical care, their legal history, those kind of things. All of those things play into what's possible and what's necessary. So first of all, we want to do what's necessary, and then not, kind of like what we said before, not backpedal, because George is a kindly old guy, we want to figure out, what, because like I said, you're putting your signature on something, and if anything can be subpoenaed into court, and I want to be able to defend whatever decision I made. This is what I recommended. Then he went and saw this guy did something to that, but you can look into records and see what I recommended. So, that's where I went with it. And this is exactly why, because he said this, because he said that, because he said this, and this is the reason why. And I always try to convey to my clients, even though they don't like what I have to say, they may not like what I have to say, they know I really say it because I care, because I want them to have the fullest life that they can have. And if you may have to say something that they don't want to hear, but if they know that you're saying it because, you really care about them, you see them as an individual, unique person, that I think you were trying to say that's why you take the time and you want them to hear their story, because you want to be able to convey to them that, it's up to you. You do what you feel like you need to do at the end of this after I give you my feedback. But my feedback is because I do care. And but if you choose something different, that's up to you too. But basically, looking at the objectives of Chapter 1 and Chapter 2 in terms of understanding substance abuse and substance dependence, and a multi-axial diagnosis, I just wanted to get you to think about, that a person is multi-dimensional, and there's lots of different areas that we have to look at, not just how much does he drink and when's the last time he drank, or smoked, or shot up, or whatever, but who is this whole person, what's going on in their life, and that's going to help inform us and develop that really helpful therapeutic relationship, because we do take the time to ask all those questions.